So for the dental implant portion here, and again, this is before we make the osteotomies in the fibula. We want to put the implants in now, and we place the implants through these guided holes. And here we have the guided set. It's important that you use a guided system so that you can place these along, consistent with the plan that you've created, the virtual plan. And so in this system, we have these guided keys. And the idea here is that of all these different keys, the outer diameter is the same. So these all fit into the guide hole, but the inner diameter changes with each key, which corresponds to a wider drill. So we start with a small 2 millimeter drill, and we're placing a 3.75 millimeter diameter implant. And so we're going to expand the hole up to about 3.6 millimeters in this case. And one of the limitations of guided surgery is that in general, the areas where you want to irrigate, the irrigation has poor access to those areas because of all this hardware we have. And so you want to have a lot of up and down. Don't push this in all the way with one drill. You want to have a lot of up and down to allow irrigation to get down in there and to allow the bone dust to escape. And as far as the depth control in this guided system, there are these hash marks on the drill that correspond with the depth of the implant. And so in this case, we're placing a 10 millimeter long implant. And it's mostly what I do, even though I'll take some 13 millimeter implants to the operating room with me sometimes as a bailout option. But the first drill is usually the most difficult, and it has to do with that. That's the one where you're actually perforating into the bone, whereas the other drills, you're simply expanding the hole. So, and we're up to this first mark, which for this system is 7 millimeters. And now onto this second mark on the drill, which is 10 millimeters in depth. And in general, I always try to go a good bit deeper, and sometimes even drilling bicortical, which we've done there. And the purpose of drilling bicortical is not to get bicortical stability of the implants. The purpose is to allow us to infinitely deepen the platform of the implant as needed. For these cases, we take the drill and with the same drill, just go all the way across. In this case, it's going to be 4 implants that we're placing here. And in these, we call them diving boards for lack of a better name, but these are basically extensions that correspond with the guided key. And if I swing this over to the other side, where we're not using the diving board, you can see how there's a little bit of wiggle. And you've got to have this wiggle just so this will fit down in there. And but what we're trying to do with the diving board is by eliminating the wiggle, we're eliminating what has been called wag. So this drill can actually, the longer you are, the more this wag phenomenon is magnified. So that's the purpose of these diving boards. So that's our first drill. And so over here in this kit, I'm going to put this drill back here. And I'm putting this guided key back here. And in this set, we just move down the line where this drill corresponds with this key in terms of the size. So now we're going to go to this drill and this key. And again, the outer diameter of this key is the same on all these, so they all fit in these diving boards. But the inner diameter changes now because now we have a drill that is slightly wider. So again, we just go through this sequence here with this next drill to widen the osteotomy. This part goes much quicker now after we've got the first one because the hole is already made. And so the first drill has done most of the work, and these simply widen out the osteotomy. And this is a 2.4/2.8 drill. And it has to do with they're tapered. So, and again, I'm going to move down the line here, and We'll go to the next drill.
And one thing to note is that Dr. Williams is working out of the regular platforms. So although the plan is to place a narrow platform, ideally, he has it for regular platforms. So if there is a spinner or lack of primary stability, he can then upsize, or as he previously mentioned, lengthen to a 13 millimeter implant to engage that second cortex to obtain primary stability.
Yeah, thanks for bringing that up. And I think it's important to note that the implants are placed through the guide holes here. And so I use the regular platform guided keys, but I just don't drill it up as wide. I just go to the narrow diameter size, which in this case, for a 3.75 diameter implant, you know, commonly in regular jawbones, we under drill to have higher stability, but these fibulas are like marble. And so I actually, in most cases, will go up to the 3.6 millimeter diameter drill for a 3.75 implant. And when I do that, it can still be difficult to really get the implant down in there. Some people will tap these. Taps can be a nice way to kind of prepare that implant osteotomy in dense bone. What I'm going to do here, I'm putting in this last drill, which is the 3.6 diameter, and I'm going to bring in our implant driver. Now you can place the implant with a hand piece. You can do it with your ratcheting torque wrench. I use this large handle, and with the implant we're going to bring in here in just a minute. With the last drill, I often will go just halfway, just to make sure that I don't get a spinner. And so what I'll do is go halfway, then try in the implant. If it's really, really tight, take the implant out and just complete the osteotomy to the full depth here. So this is our 3.6 diameter. And the first hash mark on the drill is 7 millimeters. Yeah, most of the implant companies have markings on their drills here. And so this first is 7 millimeters. The next is 10, 13, 15, and so on. So we're placing a 10 millimeter long implant in this case. So we want to drill past the 10 millimeter just to give us the room to deepen that a little if we need to. And so knowing that we're placing a 10 millimeter implant, and with this drill, I don't want to drill the full depth. I'm just going to drill about half of it. And with our final size drill, I won't go to full depth. I'll just go part of the way in, and then take this key out. So we'll try in this implant and see what kind of torque we're getting. And I tend to just use this handheld driver where we're going to take this implant on the driver.
And one thing to do is since he's gone through just periosteum, we haven't done any profiling or access subperiosteal, which is great because then you're not worrying about devitalizing your structure. The beautiful thing about having these elevated platforms is you can come underneath prior to placing your implant to make sure you don't have any soft tissue come with you, and just clear out with a periosteal elevator just to ensure you don't bring any muscle or soft tissue with you.
Now we have an implant that's loaded up on this driver, and something to point out is to talk about how do we determine the depth of the implant. And so what we do is I'm going to pick up this implant with this driver, and in our virtual planning, these platforms or these diving boards, the top of this is 9 millimeters above the platform or the top of the implant. So an important point about the implant is, and every manufacturer has variations of this, but I use this long driver. There's shorter ones, but I use the long one so that it's going to fit down through the diving board hole. In terms of the depth, you want to be able to know where are you at the 9 millimeter depth mark. And so there's different ways to do this. And on this particular driver, the 9 millimeter mark is somewhere around here. And it's 3 millimeters below this this fatter portion of the implant where the purple dot is. And this portion is about 3 millimeters. So it's about that same distance down here. So now we've got this implant that we're placing. And that depth we just talked about, we'll look at this again up close to see what that looks like. And this is still pretty tight. And so you can either back this out and tap the hole, or, sometimes what I'll do is go in, I'll advance a little, back it out a little, then advance a little more. And I guess you could think of it as kind of like self-tapping in a way. And if you over torque these, you risk, you can actually split the fibula. You can actually flower the implant platform. And so you want to kind of be fairly moderate with your torque here and not try to just overpower these. And so when I'm looking at this from a depth standpoint, yeah, so we don't have a hash mark here on this drill, but I know that the height of this fatter part is 3 millimeters, and I want our imaginary hash mark here to be 3 millimeters below that. So I kind of use that as an eyeball to know that this distance here on the skinny part should be sticking up from the platform about the same height as that. That looks fairly even there.
So one thing we really want to highlight is you can see from the neo-alveolus or the anterior fibula, you can see how the implants are perfectly lined up concentrically with the implant sleeves. But what we really want to highlight is with this offset, when we say offset, like Dr. Williams was saying, we're saying from the diving board or that surface to the actual platform of the implant. And if you look at the plan for this case, that offset is going to be this 5 millimeters, which is the height of the implant sleeve, plus the 4 millimeters from the most inferior aspect of the sleeve to the platform location. And the reason why this is so important to understand your implant system and the required offset of its guided system is you want to get your platform to the right location during this portion of the surgery. You have a single construct that's more resistant to the torque of placing the implant. After the osteotomies, even with a reconstruction bar in place, there is going to be torque, which will make it much more difficult for you to get the platform to the appropriate level. Another way to just kind of check and verify your accuracy is by having I'm calling it lingual already, but let's say the medial aspect of the fibula elevated with your guide, and then also on the outside, you can actually watch your platform placement directly. This also allows enhanced irrigation for placement of the implant.
To fully understand these guided implant systems, now we'll bring out some of the components here. A little while ago, I said when we're drilling, this first mark marks the 7 millimeters. This next one is 10, 13, 15, 18 for this particular brand. Now I hold it next to this ruler, and wait a minute, the 10 millimeter mark is actually 20 from the end. And to what Dr. Hammer was speaking about, this incorporates the offset. And the offset is defined as the distance from the top of the implant or the platform of the implant to the top of what we're calling the diving board here, or whatever the top of your guided implant drill hole is. And for this system, the offset is 10 millimeters. So what that means is if you drill to 7 millimeter, or the 7 millimeter mark is actually 17 millimeters. And that 17 millimeters is made up of 7 millimeters of the drill being inside bone, and then 10 millimeters occupying the space of the offset, which is above the implant platform. So that's why these marks are made for 7, 10, 13, 15, and so forth, but it's actually 10 additional millimeters incorporated in this. And another nuance to know about here is if I bring back in this dental implant driver that we use to place the implant, the depth of where the diving board should be it's about 9 millimeters above the top of the implant, which is right here, because this portion goes inside the implant. So why is this 9 millimeters when we said that the proper offset is 10 millimeters? And the reason is when we insert this key in the diving board, there's a 1 millimeter lip. Because when we're using the drill, we're using this key. And so that's why the diving board is created to be 9 millimeters above the planned platform of the implant. This lip makes the extra 1 millimeter. So we take this out. This key is not in the guide when we place the implant. And so that's why we want to know for the actual implant, where's 9 millimeters above the platform of the implant. So now we have the implants placed, and we've placed them to the planned depth. Yeah, and in earlier days when I was doing this, I would just put the implants in most of the way. Then I would, once this guide is off, I would go back and deepen them to the proper depth. That's actually what I used to do. But now once this guide is off, you've already made the fibula osteotomies. And so you've got this kind of bag of bones where these pieces are just really hard to hold. And for the high torque implants to deepen those is very difficult. And so that's why we started doing, we guide the position, but we guide the depth also for these. And because right now is the best time to really establish the proper depth here. And with the implants in this guide, I placed this, this is the implant driver that's used to place the implants. And I put this in here just so we can look and see how, it's coming up pretty much through these are never perfect, but it's pretty much in the middle of this hole. So this is our implant trajectory here. So now the implants are in, the predictive screw holes have been drilled, and the last thing we're going to make is these fibula osteotomies. And again, it's important to remember that this is the last thing we want to do. And so we're at the distal, at the foot end here. I'm going to do this first.
And the reason you want to go from distal to proximal is, as you can see, that as you cut, the segments become more mobile. So you would never want to make your proximal cut before your distal cut, because then you would be cutting an osteotomy on a mobile bone segment.
Some people use a reciprocating saw. I use these oscillating saws. And so I can just kind of slowly push in and kind of push and let go and just feel, do I still have bone there? And, many times we'll actually put an instrument in the back to protect the pedicle also. These tend to get a little bit dull quickly. And so I'll put a new one on for each osteotomy that we're making here.
And one thing you can see Dr. Williams is doing automatically is there's going to be one side of this oscillating saw where the head's going to be. So have that away from your guide so you don't have interferences as you get closer.
As opposed to this, where that knob starts to hit this stuff. So with this osteotomy, if you look at this diving board, we're getting a little bit close to where the implant is. And a question that comes up is, how close to this cut edge of the fibula can we get with the implant? And in the traditional dental implant literature, we like to have 3 millimeters away from, and this is native jaw bones, we like to have 3 millimeters of bone between adjacent implants. And so that's what I tend to go with, is I'd like to have 3 millimeters of bone out there. And it has to do with blood supply, because if that bone gets too thin, then, the implant's kind of in the way, blocking some of the marrow blood flow, then, you can lose potential viability of that segment there. So I try to maintain 3 millimeters of bone. And that's between the edge of the implant and the fibula osteotomy. Yeah, so now we're going to remove these fixation screws. Good. So once the guide is off, we have our segments here. And this is a two-piece fibula, so we have this little triangle of bone we're going to need to uh, remove also. Then we've got this proximal piece of bone also that we need to take out of here. Okay, so now we have our fibula cutting guide removed, and we've taken out this proximal segment of bone, and now we have these two segments here that are going to be part of our two-segment fibula construct. The dental implants are in; they were placed through the fibula cutting guide. And a point I want to make here is that in terms of getting the proper depth, the fibula tends to be a little bit sloped, where it's not a flat surface. It's kind of like a rooftop, and we're placing these implants on one side or the other of the rooftop, or maybe in the middle of it. And I think right here, actually, this one is a good example of how you can see where the implant is. There's 2 or 3 millimeters of bone above it when you look at it from this angle, and so it's a little deep there. But what's a little more difficult to see is that on this other surface, which is going to end up being the lingual surface, the implant is kind of flush with the bone there, which is more where you want it, or even subcrestal, even a little bit deeper. And so because this is uneven here, this what's going to be the buccal side is going to keep us in many cases from seating this abutment, because this abutment, this is a multi-unit abutment. It flares outward, and these implants are internally threaded, and when we seat this abutment, the bone can be an interference to keep this from being seated all the way. And so the way to manage that is, most dental implant manufacturers have bone profiling kits where you can do that. And sometimes what I end up doing is, because it's on the buccal, I may just very carefully all of that out. You got to make sure you don't touch the implant. Good. So that's our bone profiling, and I'm going to make sure the soft tissue is not down in there. And now we're going to attach these abutments. And these are straight multi-unit abutments.
Torque for the multi-units.
And the abutment is the connector between the implants and the teeth. And these purple sticks these are just handles. Once these are seated, you just kind of break these off. And the abutments are these gold pieces. The next thing we'll do is we have to torque these abutments down, and we torque them for Nobel, a straight multi-unit abutment torques down to 35 Newton centimeters, but you need to follow the manufacturer specifications for those to torque these down. And next we're going to add our temporary copings. The temporary copings are the component that's going to be picked up inside the prosthesis. Yeah. And so the fatter part down here, this sits on the abutment. And this screw, this tiny little screw, is going to go inside this channel, which is going to be how we attach this to the abutment. So now, this is the temporary coping we're going to attach to the abutment with a little screwdriver here. We're going to do this for each implant. So now we have these temporary copings, these temp copings attached to the implants, or attached to the abutments. And we also have, this defect model or resection model. It's a model of the defect created with the mandible cutting guides. And we've taken our plate and we've attached the plate to this model. And an important thing to note is that you need to put the plate on the model before you attach the fibula. because it's common to have your fibula, and you bring the plate to the fibula and attach it, and then you bring that plate with the fibula on it and try to put it in the model. And and the reason for this nuance is that this model can flex a little bit, and even with a bar across here, you can have some flex, or you can force the fibula in if you wanted to, and so, but now things are off, and now you're going to have a malocclusion, because that's a source of error that you've introduced into the case. So we've got this plate screwed to the model here, as we're going to bring the fibula segments up into the defect here. So now, as we're bringing these two fibula segments up into the construct here, one of the things we'll commonly do is, instead of using screws, we'll use these drill bits to loosely position the segments so that we can still manipulate them a little bit. And we've done it with these two drills, and see if we can find this here, and there we go, there's that one. And so what we end up doing is that we, one by one, remove a drill and replace it with a screw. Now, before we do that, these temp copings are in place, and there's a little bit of this, you can get kind of a barrel roll phenomenon, and with these segments. And so before we put the screws in, we would like to make sure these temp copings are coming in the right trajectory. And so we're going to take our prosthesis, our dental prosthesis, and seat it.
And you want to make sure before you make any decisions that it's fully seated, the prosthesis. So you can see these peekaboo windows here is showing Dr. Williams and I that the floating prosthesis is completely seated in all dimensions.
And so if we, I'm going to tilt this. So if we look down the holes of the teeth, we can see these temp copings are in the holes, and they're coming through the holes in the proper trajectory. So this is a confusing point I want to reiterate. We are not attaching the teeth to the implants right now. We're just seating the teeth over the implants to make sure that when we put the screws in the plate and in the fibula, that the implant trajectories are correct.
So one thing to be super cognizant of in your
Yes.
planning is if you look at these fibula depths right here, you can see 10.5, 10.4, 10, etc. That is a bicortical measurement. So obviously that's not the length of screw you would want to use. You would only want monocortical. You can always ask 3D Systems for those depths, so then you know with the offset of your plate plus that monocortical depth that you will not run into that medial cortex and have a proud screw. You can see that Dr. Williams is using a locking screw and then not a bone screw. The reason for this is, as he's tightening, you can actually see those temporary copings moving back and forth. We want that freedom of the bony segment and then the fixation of the locking screw to the plate. The goal is not to pull the bony segments to the plate, because then, as you can imagine, those temporary copings would not fit and we would have a malocclusion.
Another thing I'm doing here, or rather I'm not doing, is I'm not sinking these all the way tight yet. I'm putting in all these screws. I'm not locking them just yet. And it's just a way to, once again, have one final view to look in the holes to make sure that these segments are where we need them to be. Now, what if it's off? You can't do a whole lot about it, but sometimes you're just barely off, and you can have a little bit of wiggle room here. There's not a ton, but sometimes there can be enough fudge factor to really kind of save the case and allow you to continue.
And once again, to underscore Dr. Williams' point, putting the prosthesis on should be a very passive move. If your segments might have, a little bit off on your osteotomies or implant placement or the trajectory for it, that's fine. Just go ahead, grab a barrel burr or anything of your choice. And at these holes, you actually want to then open up even wider in order to catch the temporary coping. So once again, we have this flexibility in the roll of the fibula segments, but do not force it because you're putting it in an unnatural position, and that will compound errors when you bring it up to the mandible.
Yeah, let's, I think it'd be good to scrutinize ourselves here a little bit, see how well we've done. And when we look down the channel, let me see if I can move this for the camera here. So this one looks like the worst one, where it's a little bit lingual in the angulation. And you don't want this touching the walls. And so this would be an area where we may just lift these teeth up. Remember, these teeth are not attached yet. And so we would take those off and kind of burr out some of this material in the teeth over here. This one's a little bit lingual also. Now, the fact that both of these in the same fibula segment are lingual makes me wonder if also can we troubleshoot that by loosening screws and see if we can push that a little to the buckle. And there's this, what I call a barrel roll phenomenon, where these fibula segments can roll a little bit here. And again, with, with these milled plates, you're really committed and stuck to your plan here. But sometimes I can grab this on the lingual side so I can push buckle just a little bit as I tighten these screws. You can't get much, but sometimes you can get a small amount here.
And it's a fine balance tightening these screws with the teeth not on it. We're only doing that to try to offset that lingual displacement Dr. Williams discussed. Otherwise, you could put yourself outside the restorative space.
But still, I think at this point we're in line here where I think this implant is probably the best one. It's pretty centered down there. And so, what's the source of error that causes this? And in general, it's the implant positioning and the way that the implant holes are drilled through the guided system, through the diving boards. And that's a little bit of that wag factor on the drills that you can get when placing the implants. So I'll take a chance here also to look kind of underneath the prosthesis. So we've got space under the teeth, and the temporary copings here, this wider part, you want to make sure this wide part is not up in the holes in the teeth. And they need to be below here. So it's like these feet that reach down onto the abutments. And we've got a buckle hole around each one of these, which is an area where we can inject our pickup material. So now we're going to do the pickup, which means we are going to pick up these silver temporary copings inside the teeth. And we're going to do that by injecting, there's different materials you can use. They tend to mostly be acrylic resin based. And we're going to inject in these side ports here. You don't want it to get down inside of these cylinders. And actually these cylinders are a screw access hole for this little screwdriver. And actually for this demonstration, I'm just going to leave the screwdriver in there just as a way to plug the hole and prevent the acrylic from getting down in there. We'll commonly use these red straws, like from a WD-40 can type thing, or you can use Q-tips. So now it's a 7-minute set time for this to set.
So as you can see now, we're just waiting for our pickup to fully set. But you can see the screw access channels are available and not blocked out by the material. You can see with our peekaboo windows, we're still well seated and then our proper location. We have tightened all of our screws in our fibula segments.
Before we attach the teeth.
Before we attach the teeth. And really the most important thing is now that this is set, you cannot tighten or loosen any of these fibula segment screws once the teeth come off, or I promise you will roll the segments and your occlusion will be off. Just to underscore, for demonstration purposes, we've had these blue towels to make it easier to see everything, but you can see we are still connected to our pedicle this entire time. We are not on ischemic time for anything you've seen. And really just want to drive home the point from how the planning really sets the tone for everything. This long line is our identified perforator from before. This more anterior is where we said was our 12 centimeter, which it was supposed to be 1 to 2 millimeters off of our osteotomy site, which you can see is right here. So all kind of going as planned with the accuracy in all three dimensions with our resected model.
Some other things I'll throw in here is we have this skin paddle, and we make a big point to design these so that the implants are emerging from the anterior surface of the fibula, which means the skin paddle is down low in the neck. And so the skin paddle, we would rotate up over the buckle. And the reason this is important is because when you do this, the skin paddle is inset under slight tension, and as it scars down, you create a buccal vestibule. And so case selection does play a big role here, such that if, let's say, your soft tissue defect was more of a floor of mouth defect, and your buccal tissues are mainly preserved, it's more difficult to do that. The next step we're going to do is, so we've done the pickup of these temp copings, and these temp copings are screwed to the abutments, and we're going to unscrew these now because the temp copings hold these screws to make the prosthesis retrievable. Good. So if we lift this off, we're going to cut away this portion, which is like a stent that helps make this floating prosthesis. We float the teeth out in space in the proper occlusion. And but now we can cut that part away because now we've picked up these temp copings inside the prosthesis. And the other thing we're going to do is add a little more of our resin pickup material to fill in these gaps here. And so the idea is that this is going to be retrievable, meaning these teeth, it's like a bridge, and we can take the teeth on and off as needed, whether it's for maintenance or hygiene or repair and so forth.
And one of the main things, in addition to this skin paddle coming up and over the buckle, this is an opportune time to do any trimming or de-epping of the skin paddle, just in case maybe you need to move the skin paddle. Now, if the soft tissue defect was not as anticipated, or maybe it's smaller and you would trim at this site, well, it's still perfused, and you can see your perforator, and you can check for vitality throughout the entire shaping period. So this is kind of the final check before you move forward. The next step is going to be taking your construct off of the resected model. Just a reminder, all the screws that you use in the resected model obviously cannot be used in the patient as far as up in the head and neck for your fixation. So once these are taken out, I just work with my surge tech, and we just make sure that's in a burn pile, and we make sure it absolutely does not go up to the head and neck. And as you can see, as we're taking the plate off, we do have some features that will help us in the head and neck to register this construct. One of them is the flanges here that grip the native mandible for registration. In addition, you can see the differences, the space between some holes and the close proximity to others. So with this new type of plate design, you can be a lot closer than you've been able to put your holes in the past relative to each other. And then increased thickness, which also wasn't a previous option.
The material I'm using has about a 7-minute set time, and once it sets, then we've unscrewed this, and we've got to make sure each of these temporary cylinders are immobile. And you just want to just gently just touch these to make sure they're rock solid and not moving. And then on this undersurface here, I'm going to use our material again just to fill in some of the gaps. Just a few small gaps here.
And usually as this is being done off the field, not on the
Yes.
field, usually I'll be making my final preparations with the reconstruction team, make sure everything looks as planned, and then that's when we isolate our vessels and go ischemic. While we transfer our mandibular construct from the leg up to the head and neck, that's when our prosthodontic or dental colleague is doing something called a conversion. Dr. Williams spoke about it earlier, but what a conversion is taking this splinted set of teeth, removing both the splint and the bars, and then smoothing the surfaces to create the final prosthesis for this surgery.
And this is where we're off on the back table where we're going to trim away this extra material here. And sometimes we even just use bone cutters, kind of like the rongeurs, and then also doing some smoothing and polishing as we need to for the prosthesis to be ready to be placed in the mouth. And so now at this point, we've completed our conversion where we've converted this prosthesis to it's basically a bridge that attaches onto the implants here. On the undersurface, you want to have these, what I think of as the feet sticking out. You don't want those up in the prosthesis.
And you can see how Dr. Williams is putting this on, and it's very passive. Once again, that just assures the accuracy.
Yeah. And this is why, once you attach the teeth to these copings, you cannot change these screws at all. Because if these fibula segments rotate or move in the slightest bit, this will no longer seat. And I've got the screws down in these screw channels here. And I'm just doing these kind of finger tight here. For Nobel, the manufacturer specifications say these should go to around 15 Newton centimeters, I think. So now we have this, our full construct here of our fibula with the teeth, and we're still at the leg, still perfusing on the pedicle here. And so at this point, we're going to simulate our ischemia time, and we're going to move this up to the head to complete the reconstruction. So we take the pedicle pretty much as high as we can to maintain our pedicle length there. So we'll go up near the takeoff from the larger vessels.
The next part of the case is bringing up that mandibular construct up to the head and neck. Once again, you'll see Dr. Williams and I, as we use our predictive screw holes to do our inset to kind of guide us. Because the predictive screw holes, you do not need MMF or like an IMF screw set. One of the things to consider, though, is if this is not passively happening for you for this bony inset, and you notice a malocclusion, there may be more reduction of either the native mandible or the fibula segments in order to optimize its location. What Dr. Williams and I are doing before we're committing with our screw holes is we're going ahead and registering the locations of the predictive screw holes. And you can see how I'm de-auto-rotating the mandible. Obviously, the medial pterygoid and the lateral pterygoid are going to pull it forward. So just put the ramus back where it is. If you need to use a ball clamp, a ball plate clamp, you can do that. Once again, you want this to be as passive as possible. See Dr. Williams putting that on right now. Once again, we're using locking screws into this milled custom plate. And you can see it on this anterior because it's probably easier. I'm looking for that flange adaptation just to give me that three-dimensional stability and conformation. So now we have a clamp on both sides, and obviously the biggest way to know if you're in the right spot is to check and see if the native occlusion is stable and repeatable. And so you can see on this right side, let me get a better view for you. You can see that the patient is in their stable native occlusion.
And there's a little bit of a step where the prosthesis here meets the native dentition, because we purposely want to make these 1 or 2 millimeters short, because these teeth are for smiling with, they're not for chewing with. These are the temporary teeth they wear while the patient is healing. And so we purposely we designed these, in this case with the floating prosthesis, to have them digitally positioned 1 or 2 millimeters inferior from the true occlusal plane against the upper teeth.
And then now that we've checked the occlusion and we're happy with it, no need for any modification to our fibula segments or native mandible, then we can go back to our plan and understand the depths of our screws needed. Usually we put one on each, the proximal and distal segment to begin. Perfect. So now that we have a stable and repeatable occlusion and we see our hypoocclusion as planned, 1 to 2 millimeters out of occlusion on that left reconstructed aspect, we then go to our plan to look at our bicortical depths. So usually always go 2 millimeters longer than planned to ensure contact with that second cortex. So Dr. Williams right now is placing a screw into the proximal segment. And similar to what we did with our fixation screws in the fibula, as we seat our screws, we will then take out the drill bits, which are holding its place. And just a reminder, if you look at our plan, if you look at the proximal segment on that left side, we really have 3 predictive screw holes here, but you can see the way we design the plate, we have 4 screw holes. So this is just a reminder, if you have a hard time getting that last hole in, it's because you actually need to drill a hole. The same thing is true on the right side. It only has the 3 predictive screw holes, and then you just do the 4th once it's in. There's absolutely no reason why there needs to be 4 predictive screw holes in the guide. All that would do is make it larger. You would need a larger dissection, and you wouldn't get any benefit with the 2 to 3 holes in. You have that anti-rotational nature of that plate.
So while Dr. Hammer's putting this last screw in, I'll comment on, a common source of frustration to pay attention to is this area where the prosthesis meets the native jaw. And it's not the tooth usually, it's usually this bone here. And because remember, this portion of the cut of the mandible, we kind of freehanded it. So if these teeth are touching the bone there, and we've got a little contact there, and so what we should do is we remove the prosthesis and we just smooth that back because we need room for the soft tissue, for the gingiva to grow through there. So that's a common source of a reason why you may not be able to get your plate to line up. And so at this point, with the closure, how do we close the soft tissue under the prosthesis? And there's a couple of approaches. And, in this case, we brought up a skin paddle also. And so with the prosthesis, if these are designed with adequate space underneath, then you can pass a suture through there to close this. Another way to do it, we'll show you, is to remove the prosthesis and place the sutures, but don't tie them. And we just have these parachute sutures that we tie after we replace the prosthesis. The vascular portion, it kind of varies. And I think Dr. Hammer does things a little bit differently than I do because in our program, I'll have our fellows typically get started with the vascular anastomosis while I might be completing the conversion or prettying up the teeth a little bit. And you don't want to just delay your ischemia time.
Yeah, and what I tend to do is bring up the construct, and once the bony aspect and the occlusion is verified, I will start insetting the skin paddle in all aspects except directly where the implants are. Once I have that soft tissue closed, except for where the implants and the teeth are emerging from, which will show you how we do that closure in just a minute, then I will go do the microvascular surgery and the anastomosis. And then really all that's left after the microsurgery is just doing my parachute suturing and closing my oral side.
And again, this just shows how I've still got the little screws down in here. So this is a retrievable prosthesis. We don't like to call it removable because that implies the patient can't remove it with our dental terminology. But this is retrievable, so we can take it on and off as needed during surgery and afterwards. And so here with the prosthesis removed, we can take our lingual tissue and whereas it could be the buccal skin paddle, or it could be native gingiva. And actually, in this case, we were trying to make a point of how we preserve the gingiva. And we normally don't have a lip split. We're doing it just for better visualization here. But we would bring this in and place our sutures. But in this case, let's use a skin paddle to demonstrate that. So now what we're showing is we've placed some of these interrupted sutures, but we've not tied them. And these are all separated out. You put them on hemostats or something. And the next thing we'll do is actually seat the teeth back on. And again, the screws are down in there in the teeth. I usually just place one suture between each pair of implants.
You can imagine this is now bringing together the lingual mucosa with our skin paddle. And what you're looking at is the new buccal vestibule for the patient.
Yeah, so in the continued closure here would obviously be bringing this up to our incision line out in the buccal area. And so with this orientation of the fibula and skin paddle, what this means is that because the skin paddle is coming from below, when this heals, you actually get a crease that forms where the septum comes up to the skin. The septum scars down a little bit and makes a crease, and that's what our buccal vestibule is when this heals. So now at this point, we've reapproximated the lip split, and now we have our final bite here. Again, the occlusion is maintained with the natural dentition, and we've got a couple millimeters of space to put the other teeth out of occlusion because these teeth can be functioned on during the implant integration process. Post-operatively, in terms of the diet in the hospital, I think it doesn't change much from most of our traditional fibula cases where they have a few days of a tube feed at minimum, and over the next few days and weeks they're advanced to soft, mushy diets. And again, you can't have the patients chewing on these teeth. These are the temporary teeth. And once 3 to 6 months later, the implants are verified to be integrated to the bone, then the final teeth are made.